this event, and it's really delightful to see how it's grown and how many people are showing up. The first one, we had 10 exhibitors at like picnic tables in the halls, but I'm also pleased to see that last year Tom Dowd came here and Sarah came, and they were upset because they were the only two people who thought about behavioral health here, with maybe one or two other exceptions. So they decided that they would do a session on behavioral health and asked me to lead it. So we're going to hopefully interest you folks in why mental health should be covered in this. And I'm now working at Ashoka, running their health and nutrition efforts, and then working with Centerstone on their extension of service to others. So if we could have the first set of slides, maybe we can get going here. So who took, oh, here's the device. If you, they have a new system of slides this year, you may have noticed, and for those of you who have, on the technical side, have worried about interoperability, you may have noticed on day one that these devices were interoperable with the room next door. So we had a lot. It was like the early days of extendophones. You may remember that if you're old enough, you could listen in on your neighbors' conversations. But no, that would be the third presentation. This is the one that doesn't have a name on it. An individual's name on it is the one I want first. It's 124, I think. I think one of the things that vamp here as we're waiting for the slides is really important to recognize is for thousands of years we had a, 124, please. Oh, no, if that has dress on it, the Aylward, 126. I'm sorry, there you go. There we go, perfect. We say an almost untouched opportunity because of this. If you are looking at the biggest reasons why people are sick, why they're missing work, the number one cause in the world is depression. And it is a huge problem in the United States where we spend lots of money on these issues. It's a really huge problem where I spend most of my time in Africa and South Asia, and almost no money gets spent in addressing it. So this is a very big issue and needs to get dealt with. These are American numbers, $100 billion. There's an awful lot of conversation outside this hall and in this hall about the costs of non-communicable diseases, of diabetes and obesity, and which I would suggest we might look at nutrition as the problem. But very little conversation about depression. There's a lot of conversation about how hard it is to get employers to focus on the well-being of their employees because they don't get a return on investment. Well, anybody who's been depressed, as I have, I was been clinically depressed and treated successfully for it, you know that it kind of impacts your productivity pretty fast. So there are a lot of Americans facing depression, and just about 2/3 of the people who kill themselves, causing untold harm to families. If you've ever been around a suicide, you know the costs of that, not just to the person involved. There's significant economic and social costs here, and whether you worry about people or you worry about creating a business, and we hope that both will come to focus on this area, there's major opportunities here. And there are major opportunities because, with due respect to I live in this city, and so I hear the political class talking a lot. There seems to be this belief we have the best health system in the world, and we don't. We have the most expensive health system, that's for sure. We are number one in the cost per capita of health system. We are not number one in anything else except for gun-related killings and harm. But there are real numbers here that we have a broken system. And interestingly enough, a lot of the world is heading in our direction. If you go to India, what they're doing is setting up acute care systems, and they're setting up insurance for acute care. which is kind of just what got us into this mess. But interesting enough, as part of that overall high cost and low returns, here are a few numbers for you. I was astounded to discover that 66% of Americans who are depressed don't get treatment. So with all of that, we're not reaching 2/3 of the class. I mean, you imagine if we had malaria in this country, we're only reaching 1/3 of the people that have it. I just came from my favorite focus area abroad is moms and babies. And we talk about how, you know, in Bangladesh, only 20% of the women give birth in a facility. Well, if you saw the facilities, you'd understand why. But these are shocking numbers. One of the ones that's really bad, and this is not just mental health, is research to practice. I mean, if we had numbers anything like this in any other industry, you'd be out of business. I mean, imagine the tech industry doing research and applying it years later. I mean, this model we have of I've got an idea, let's do research. Okay, let's get some professors, let's go out, and then we'll find 20 people, and then we'll write a paper, and then we'll get it published a year from now, and then, you know, I mean, it's crazy. And yet, when you say that to people who do research in this field, they get really upset at you because that's the way they've been doing it for some period of time. So we've got a broken health system. We focus on sick care, not wellness. Most people who are really sick have comorbidities, but what we do is we treat individual illnesses with different doctors without coordination between the two. Most of those chronic diseases, severe ones, include a behavioral health component. But one of the frontiers of coordination here is physical and behavioral health, which is, like, for people who aren't in our business, is a mind-blowing thing that we don't coordinate those. And yet, what do people really want? I mean, people don't want to be sick, but what they really want is vitality. They want to get up in the morning and feel good. And in order to deliver that, yeah, you've got to do physical health, but you've also got to do behavioral health. You've got to do, if you have a bad environment around you, whether it's physical security or the air you breathe, that could be a problem. And you need nutrition. I mean, if we don't deal with what we're putting into our bodies, so there's a holistic set of solutions here, and we are playing with individual silos of people's bodies using a research method that takes facts and implements them within 2 decades. It is remarkable that we talk about food security around the world and people not having enough to eat, and yet what they aspire to in many instances is what we've achieved. And what this is starting to do to us in a health capacity is really bad. And I'm not going to spend, I run the nutrition program at Ashoka, so this is like tooting our own horn. But unless we deal with this, we're not going to solve the physical health problems we're talking about in other rooms, and it has a significant impact on the behavioral health problems. Now, the good news is that we're at an inflection point in what we're able to do. And I took this picture in Bangladesh, rural Bangladesh, half a mile from any road. We had to walk in because, and this is one of Muhammad Yunus's famous microfinance circles that meets every week. And they meet every week to take out loans and talk. And I said, who's got a cell phone? You can see everybody's got a cell phone. And by the way, the coverage is better than downtown Washington. And beyond the cell phones, this was taken at the mHealth Summit 2 years ago. We have devices now. We have devices that measure how nervous I was at that particular time. It makes my heart rate is 120. My heart rate is usually 70. When I went down to hug my fiance, it went even higher. But but we can instrument people. So we can develop data from both the voice and the communications they have on their phones and from a whole variety of things. So mobile is really changing everything. We can deliver behavioral health to wherever somebody is. We can break this facility paradigm of you get health by coming to me, by coming to my office, by coming to my hospital, coming to my business. We can have sensors on the body. We can have sensors in the pill. 5 years from now, every psychotropic drug or any drug you take for any purpose, significant purpose, will have a transmitter in it. And it'll go to your phone and it'll report that you took it, and the sensors on your body will report how you're reacting to it. We can have real-time monitoring of what's going on with people's health, not showing up at your shrink 2 weeks from now saying, you know, I was feeling really bad 2 weeks ago, and then trying to unravel what was going on. Allowing major changes of professionals operating at the top of their licenses, which is a nice way of saying we don't need to have people with medical degrees doing entry-level work, and we can't afford it anyway. We can integrate between physical and nutrition. We can, and this is really fundamental, I think, and things we want to talk about, is shifting to multivariate variant data analysis on holistic measurements of people. And most important to a research panel, being able to increase the development of knowledge and its dissemination, which I hesitate to point out, we're kind of the last holdout in the world against using information technology this way. Think about behavioral health in the future in this kind of a stack, where the left hand, the top three are what we do today. The bottom four are what we're starting to do and can do tomorrow using these new technologies. The key here is not to shift from one to the other. The key is to integrate them. The key is to have systems where people are. There are an awful lot of people who are not going to walk into the facility looking for mental health, who can't afford it, or we can't afford to deal with them, but who are playing games, who are online, who could be brought into a system, which will allow us to really develop personalized responses to them using social media where people are as a central part of this, not a sideshow. Because if you even the most successful websites like Patients Like Me have tiny numbers compared to the Facebooks of this world. And let me mention one other thing before I turn this over to my colleagues on the panel. Beyond the health of the individual, there's new data being developed that I say, Kevin Bacon, 6 steps away from Kevin Bacon. Nick Christakis up at Harvard and some others are doing amazing research that is talking about if you're happy and you know him and you know her and she knows me, that I'm more likely to be happy. Or if you have diabetes. So what public health people have been saying for a long time, it's, hey, the health of the community is important, is in fact scientifically true. So as we think about the future, just to bend our minds a little bit, we need to think about treating the mental health of the community and the physical health of the community, not just the individual. So we have a panel this morning with 2 first-class researchers and then 2 friends from NIMH who are going to react to what's being said. Let me introduce Sarah Lord from Dartmouth, my alma mater, and who is one of the leading researchers on applying these technologies to behavioral health. Sarah.
Perfect. Thank you. I am charged today with presenting a broad swath of the work that we do at our center. So what I'm going to do is present talk a little bit about the Center for Technology and Behavioral Health, sort of who we are, and then I'm going to launch into a rapid-fire description of some programs. And so anybody that's interested after the presentation to talk about in more detail some of these research lines can do that. I work at the Center for Technology and Behavioral Health, which is that part of the Dartmouth Psychiatric Research Center. It's a P30 Center of Excellence funded by NIDA, really with the mission to be a national resource to enhance the quality, pace, and achievement and impact of research focused on the very things that we have all been seeing here at this mHealth conference in terms of innovative development, harnessing technologies, evaluating, programming, and dissemination of technology-based therapeutic tools. And our target is in particular in the areas of behavioral health care. So our goal really is to collectively lead to transformations ultimately in the delivery of evidence-based behavioral health care. So I won't reiterate this, just to provide the context of the programming I'm going to be describing rapidly, building on what David just described in terms of the potential for mHealth. The first line of research is led by my colleague, Dror Ben-Zeev at Dartmouth, and his other colleagues, and it really focuses on mobile assessment and treatment for schizophrenia. It's a line of research that harnesses ecological momentary assessment, text messaging, and couples it with CBT techniques to deliver treatment real time to folks with schizophrenia as they're out and about and living their lives. The initial program harnesses basic mobile feature phones, so it's very simple to use. They used a collaborative user-centered design approach to develop a set of EMA text message exchanges targeting 3 outcomes: medication adherence, social interaction, and auditory hallucinations for folks. Here's an example of the text exchanges. The client individual might receive something: "Good morning, have you been bothered by voices today?" Depending on the response, they would then get a question about their belief set regarding voices, to which the text response would be something to challenge this negative belief set. And then they'd be given a short homework exercise, if you will, to again challenge the negative beliefs. So this team has developed a whole array of these text exchanges targeting the outcomes I just described. In a pilot, they piloted this intervention. It's a 12-week trial where individuals received 3 sets of these EMA texting exchanges over the course of 6 days a week over the course of these 12 weeks. They tested it with 55 patients with schizophrenia, adults, primarily adults. And here are their results. They're very positive. In terms of feasibility, 86% responded to the outcome assessment, so they had very good engagement with this intervention. The majority returned the phones. Sometimes we think that potentially when we provide folks with mobile phones, we're not going to get them back. That's just not true. People were engaged and they returned the equipment. Even more promising were the results in terms of the target outcomes. The pilot, they saw a significant increase in medication adherence, and this was particularly the case for folks in independent living who at baseline had reported lower adherence because they were living on their own. They often forgot to take their meds. So there were strategies as part of this intervention that helped folks develop a plan for when they to avoid forgetting taking their meds. They also found an increase in social interaction, a decrease in severity of hallucination symptoms, and also a decrease in the negative beliefs regarding these target outcomes. So these were very promising pilot results and good preliminary efficacy. And the plan now is Dr. Ben-Zeev is to develop a smartphone application of this intervention that will then be tested in a randomized controlled fashion that will be more comprehensive in terms of the self-management skills that it includes. As an example of a line of research that uses mobile technology as an adjunct to care, my colleague Lisa Marsh and others at the National Development and Research Institutes in New York have developed a mobile psychosocial treatment, which is essentially includes a functional analysis of drug use, so the thoughts and feelings associated with drug use, the contexts and situations associated with their drug use. They identify triggers and then come up with a coping plan, essentially, to manage the triggers. And this very simple intervention that then just provided prompts as a reminder for these to review the coping skills twice daily. In a pilot of this intervention with 50 folks who were in methadone maintenance treatment, they compared this mobile phone psychosocial treatment module, again, a very simple approach using standard feature phones against the standard of care for methadone maintenance treatment. They tested it for 12 weeks, and they showed very good feasibility and acceptability in terms of participants maintained the phones for the duration of the study. They used the mobile program modules as intended. They reported high levels of acceptability of the program, how it was easy to use, it was useful, they would recommend it to a friend. These are all very important indicators of engagement. And importantly, the majority of participants reported using the mobile intervention during times of heightened risk. So they really integrated it into their routine, which is sort of what we want in terms of sustainable dissemination, implementation of evidence-based programming. The results of this pilot, again, were excellent. Those who used the mobile treatment showed increased treatment retention over the 12 weeks compared to the standard treatment, and longer periods of opioid abstinence over the 12-week period. That intervention is now being developed in a more comprehensive, to be more comprehensive, and is going to be evaluated in a randomized trial funded by NIDA with about 250 folks in methadone maintenance treatment. So another line of research that Lisa Marsh is conducting, this is in concert with Dave Gustafson from the University of Wisconsin, is to think about technology-assisted treatment of substance use in primary care settings. So we know primary care is increasingly being called upon to provide behavioral health care services, including substance use services, mental health services, and HIV services. We know with healthcare reform that the demand for care exceeds the provider supply, and that we're really in need for care outside the boundaries of clinic settings. So what Dr. Gustafson and Marsh are developing is an integrated care system using a personalized mobile therapeutic support system that they are going to develop and evaluate in federally qualified health centers for FQHCs throughout the country. What this is an integration of two evidence-based mobile interventions. One being the therapeutic education system, which is an addiction treatment program that's actually been being tested currently in the NIDA CTN trials. It's really a skills training program that's had very good that has a very good evidence base. And that's being paired with HS, which is a recovery support program developed by the folks at University of Wisconsin that really focuses on social support and promotion of coping skills and resources after care. So the goal here is to develop a patient registry, essentially an interface, that allows for screening and triaging of patients as they come into the FQHC clinics. This team is going to evaluate, using a stepped wedge design, this intervention in 4 FQHCs, and really the focus is going to be on implementation. So it's really an implementation science project where they'll be looking at organizational and patient level outcomes in terms of reach, in terms of effectiveness, for whom does this integrated system perhaps work the most or best, adoption of this system, implementation of the system, and maintenance. In terms of ongoing health promotion, the work that one line of work that I've been involved in has been on integrating, harnessing the web and text message technologies, really, to promote HIV testing and sexual health for young people at particularly high risk. So we know that there's continued high prevalence of HIV and other sexually transmitted infections among young adults. And this is particularly the case for those young adults of color. We also know that easily accessible ongoing education and early intervention is key, and that we really need to provide this sort of prevention education outside the boundaries of traditional care settings. So what my colleague Al Cohall and his team at Mailman School of Public Health at Columbia University are developing is really an extension of a community-based sexual health promotion initiative that they are currently undertaking, which is to provide workshops, in-person workshops to community-based locations throughout metropolitan New York City. They provide sexual health education, rapid testing, and referral. The problem, or the barrier here to this intervention, is that it's very time and resource intensive, and it's a one-touch sort of connection with the participants that show up at these workshops. So what we're currently developing with support from NIMH is a integrated mobile text message intervention to promote HIV and STI testing among young people, as well as condom use and reducing other sexual risk behaviors. The intervention is really an adaptation on an evidence-based web program that I was involved in developing for college students. It's based on the information, motivation, behavior theoretical model, where we're really trying to build awareness around HIV and STI testing, promote motivation, and foster skills to help young people get into testing and use condoms. We're using a user-centered development approach that includes a young person advisory board. They essentially are the content and design producers. We provide sort of the scaffolding around the theoretical frameworks and the content of what we know works, but they really are tweaking that content and writing the content to make it engaging and relevant for them. The program will be includes an online risk assessment with tailored motivation, and then comprehensive sexual health education to promote awareness and motivation and build skills for condom use and testing. We're using the text messages based on as reminders and motivational enhancement tips and skill building tips because we got fairly solid feedback from the young people that they really don't want comprehensive information coming to them on their mobile devices. They just want sort of quick hits on mobile devices, and they want the comprehensive material on the web. So that's how we're developing. This is a pilot that will be taking place in the summer of 2013 with 90 young adults, and folks will be receiving the text message intervention, 6 texts a day, focused on target outcomes, knowledge, motivation, behaviors, and really on optimizing implementation. So we're less concerned here about we certainly want to demonstrate some preliminary efficacy, but our real focus is how can we optimize implementation of this intervention in a way that could be used in real life. So another line of research, I know, how am I doing time-wise? 2 minutes, is it's called enhancing evidence-based supported employment with technology. So we know that in addition to managing symptoms for folks with serious mental illness, there's also a component of helping folks integrate back into daily living and supporting them in that effort. So we know through working is a key component of recovery for those with serious mental illness. And the individual placement and support, IPS, supported employment vocational rehab model has like a 25-year history of demonstrated effectiveness nationally and internationally. This is a community-based team support approach. It involves it's really a wraparound kind of approach to supporting employment for folks that includes consumers, voc rehab providers, employment specialists, families, and employers. It's very people-intensive. The target is competitive employment, and the intervention itself has really been shown to enhance employment, both getting jobs, staying in jobs, job satisfaction, self-efficacy, self-management, and really quality of life for folks. In the face of diminishing resources, given that it's a high people intensity sort of intervention, this limits the capacity to further broaden the reach. So we have received funding recently from the Department of Education to develop a technology-based management system to enhance IPS evidence-based supported employment. Briefly, the system is going to include self-management tools that are going to be mobile device-based. This is for consumers to enhance learning, provide means for ongoing assessment of symptoms and functioning, self-management and coping, being able to readily access self-management and coping strategies, and provide support. It's also going to include collaboration tools, so the consumers can work with their employment specialists in a more collaborative way, and perhaps, hopefully, to help the workflow of supported employment in terms of developing a career profile, developing a job plan, and really being able to gain employment and stay employed and build efficacy for consumers. There's a data management reporting dashboard that will also sort of help with case management. So I know I'm out of time, but the last line of research that we're just getting involved with is very preliminary in terms of what we're doing, but this is making sense of wearable and making sense of sensors, really. And so throughout this conference, we've heard a lot about how the pace of technology development really has, in some cases, many cases, has exceeded the science. And this is particularly the case in the behavioral health arena. The field is in early stages of being able to identify in vivo triggers. And so what we're doing is harnessing ubiquitous computing, really, wearable sensors and sensors that are in mobile phones, and coupling that with EMA self-reports of smoking, craving, stress, and mood, and we're trying to map smoking behavior and craving with wearable and mobile sensors. And I'm out of time, but the goal of that is really to do basic research to really establish practical feasibility of all this data collection, as well as to identify precursor signatures of smoking behavior and craving. That's it. And we also have 2 postdocs available, so anybody's interested in that, see me afterwards.
But you need to play football. Thank you, Sarah. Next speaker is Dr. Ben Druss. Ben is one of the nation's leading experts in this field, and he is the Rosalind Carter Chair at Emory in this field. So, Ben.
Good afternoon.
There you go. Oh, here.
So, maybe I'm just getting hungry, but I was thinking about dim sum, and in a way, what you're getting a little bit this afternoon is all these little tasty kind of different descriptions of programs. I'm going to continue that a little bit, but I also want to give you at least my kind of the menu, how I think of how information technology fits, why it's particularly important for behavioral health, particularly for people with serious mental illness. And then I want to end by kind of segueing, bringing it out to some of the areas, the challenges that I think we're facing in research and some of the questions that we have moving forward. So this is about health. This meeting is about health, of course, and the buzzword in health, thanks to Don Berwick at CMS, is the concept of the triple aim, which means improving quality of care, improving outcomes, and bending the cost curve. And just briefly, people with serious mental illness, and here I'm talking about typically poor people with illnesses like schizophrenia, but also including conditions like depression, are really what is getting in the way of, as a country, are being able to fulfill each of these goals of the triple aim. So people with serious mental illness get worse mental health care, they get lousy general health care, they're extremely expensive, we heard about this a little bit initially, and they die prematurely. So really this is a population, it's a disparities population, it's a group who's getting poor quality of care, poor health outcomes, and elevated costs, and there's an enormous need to do better for them. And so the way I think in terms of health information technology in general, I'll talk a little bit about mobile health, but I also want to kind of just think about technology in general is in terms of three ways in which it can potentially improve care. One is by extending the reach of existing interventions. Second is being a piece, basically a support for broader quality improvement efforts. And then the third is maybe what we're hearing about the most of the conference, which are standalone interventions, and which is, often you're seeing in mobile platforms. And I'm just going to give you an example of each of these and kind of why, they might be valuable. So, extending the reach basically means, taking a treatment that we already know works, but being able to reach a population who has been difficult to get to otherwise. And particularly in behavioral health, this is important. In behavioral health, that is mental health, substance use, there's a shortage of providers and a maldistribution of providers. So you may have a lot of providers in New Haven, Connecticut, but very few providers, especially in rural areas. So you really need technology to be able to reach people at a greater distance. Also, it's kind of behavioral health. Most of our procedures are like using our mouths and our ears. They're the kinds of things that work well at a distance, and so are a good fit for technological interventions. So here's an example of one. It's like many, and this is, I'm going to get to this in the end, but keep this in mind. This is kind of a pre-mHealth information technology kind of intervention. It's a telepsychiatry program. So, we can't forget that in terms of information technology, things like telephones, right, are amazing tools. They've been around for a while. In this case, it's just a T1 line going from the University of South Carolina, where you have a group of psychiatrists, psychiatric residents, who are providing consultation to emergency rooms throughout the state of South Carolina and providing round-the-clock psychiatric consultation. So this is the problem that they were filling, is that these sites often did not have access to psychiatrists, to psychiatric care, so patients didn't get very good care. They sat in ERs for a long time, ended up unnecessarily hospitalized. We're working at Emory to help the University of South Carolina on the evaluation of the program. using a large all-payer data warehouse that exists in South Carolina. And, you know, it's work in progress, but it really looks very promising in terms of being able to reduce inpatient stays, total cost of care. So we've extended the reach, you know, traditional intervention, but reaching into places that would otherwise have been hard to reach. Second is the use of IT as a support for more complex quality improvement interventions. You know, again, really relevant for behavioral health, in part because these are the kinds of interventions that are probably the best tested, the most widely used in research to be able to improve quality of care, these collaborative care models, team-based models. And IT is really, if you look under the hood of these models, one of the things that really makes it work. Functions like registries, you know, keeping lists of patients, how they're doing, calibrating care, if they're getting better or not, really it's a key supporting function. And so one area that we're working in is on personal health records. Again, this is a project that we've been working on now for about 3-4 years. It's a web-based personal health record. You know, particularly in behavioral health, you've got multiple different records, some paper, some EHRs. Linking those up is very challenging, and the thought is if this can be owned by patients and they can access it from wherever they are, it may be a way of addressing fragmentation and share information that's owned by them. It helps get around some of the challenges, particularly in behavioral health, of sharing information across sites. And we are currently analyzing the results from a randomized trial, but again, preliminary results indicate improvements in preventive services use. We'll have a number of other outcomes that we're looking at, but just another example. And here's an example where we developed an intervention based on the technology, sort of the best technology that was available when we wrote the grant probably 5 years ago, which was web-based. And now really, you know, how do we move this to a mobile platform, both in terms of patients being able to hold it and take it with them, but also being able to directly interact with the portals, the EHRs on the medical side and the mental health side. So I'm going to give you an example on standalone interventions. We've heard a bunch of different kinds. One that we have the good fortune to be working on now is casual game, right? Because that's the ultimate example of something that just sits on your smartphone. You can do when you have time, but it's not something that has to be linked to a broader intervention. I'm sure you all know which game this is. And, you know, here again, this is a little bit, we heard from the last talk about, you know, health behaviors, right? So people with serious mental illness have a huge number of adverse health behaviors. They have elevated rates of smoking, poor diet, physical inactivity. We heard about other kinds of substance use, risk activities that they may have. And mobile apps, you know, have this advantage that they're always with you, and then they also have these other cool things, like you can tell where they are at all times, you know, geolocation capabilities. And so, you know, there is a question when you're taking widely available apps. You know, there's something like 5,000 health apps available in the Apple Store at this point. You know, how do you figure out which are the right ones to use, and then what sorts of adaptations do you need to make, particularly when you're looking at vulnerable populations? Poor people, and then in the case of people with serious mental illness, potentially cognitive limitations, right, symptoms of the illnesses, health literacy, socioeconomic disadvantage. And so you know, this is sort of what we're trying to do here. We're working with a game that was developed by Georgia Tech researchers for somewhat similar demographic population, Southern African Americans. It's a diet game, which includes general menus, culturally appropriate soul foods. You have a player who's the waiter who has to decide which is the healthiest options. makes the recommendations to the customer. If you don't do it fast enough, the customer gets annoyed and leaves. You know, it's a casual game. And then the question is how to actually take this and move it into a population of people with serious mental illness. So I want to end with some questions that I hope we'll be able to think about with the other presentations, with David's discussion, and then perhaps with all of our discussion, that just have to do with this whole issue of how do you do research in this new space, this information technology space. So iPhone didn't even exist 5 years ago, well, 6 years ago. It's really evolving rapidly, and it's very different from how typical research studies work, which have something like a 5-year minimum cycle to do a study, probably more like a 7-year, and then not even counting, as David talked about earlier, you know, the time that it actually gets out into practice. So how do we avoid skating to where the puck was 5 years ago, you know, which is the challenge, I think. And I think what that's going to take is really thinking about what we mean about generating knowledge, how we make that something that's more dynamic, process-oriented, bidirectional, where knowledge is used, new knowledge comes in, feeds back into intervention studies, models like adaptive study designs in which the study can change based on information that's coming in while preserving internal validity, using large data sets. And then finally, making sure to use the very evaluation capability that is built into IT interventions. So we have this new ability that we'd be crazy not to use to track how people, for instance, are using a personal health record, to track a person's physical activity if you're doing a study with a mobile app. So, you know, that's the question that I guess we should be thinking about, perhaps, is, you know, there's this very exciting new world of technology in general, mobile technology in particular. How can we begin to update our way of thinking about research and make it match these new capabilities? Thank you.
Thank you. Our final presenter is Tom Daub, who is the CEO of Centerstone Research Institute based in Nashville. Tom?
Very good. So today I really want to accomplish three things. As David mentioned earlier, I came to this meeting last year and was really struck by the lack of discussion around behavioral health. There's some familiar faces, so I'm not the only one in the room, but and I was determined to come back here and really start a broader dialogue around behavioral health because it's such an important part of solving the overall healthcare problem that we have. So there are really three things I'll talk about. One is I'll dig a little bit deeper into some of the numbers around the intersection between behavioral health and health. I'll talk about some of our work and a partnership that we've established nationally among behavioral health care providers that is it's a provider partnership, but the intent is to create a laboratory through which we can bring new innovations to market. And I think that's something that for those of you in this room who are entrepreneurs and technology developers, I think there's an opportunity for potential collaboration and getting some of your ideas out there into the mainstream that I'd love to talk about. And then we'll close and really think about where we're heading into the future and what this means for research methodology and design going forward. So just a little bit about CRI. We are a research organization that is attached to a large provider organization. Centerstone, the company, serves about 70,000 people a year in Tennessee and Indiana with mental health and substance abuse issues, primarily outpatient services. My charge with the Research Institute is to take research and technology and use it to improve the care that we provide. Thus my interest in this meeting and mobile health in general. About 5 years ago, we established the Knowledge Network, which I'll talk more about in a moment, which is this partnership. So going back, these are a little bit dated, but going back in time, I'll start with a quiz. So in 1994, I'd like to hear some responses. On average, if you had to think about people with serious mental illness, how much earlier would they typically die than people without a serious mental illness? Any guesses from the room? I hear 5, and I hear 30, and I hear everything in between. So at that point, it was about 15 years. So let's fast forward 10 years in time. Let's see how much progress we have made. And of course, Ben had even more current numbers in his. Any guesses? Okay, pretty good. So 25 years. We've actually lost ground over time. You know, and as Ben pointed out in his presentation, it's not the issue of people dying early because of direct relation typically to their mental illness. It's the other comorbid health conditions that they have. So if we look at, this is from some hospital data from ARC, published a couple of years ago. You look at hospital readmissions. So this is a problem that many people are trying very hard to solve because it's an important issue in our healthcare system. 2 of the top 4 leading causes of hospital readmissions are mental health and substance abuse issues. Yet we rarely focus on them when it comes to the interventions that we have been developing. When I go down into the show floor, I see a lot of focus on apps and tools and things that could help address readmissions. I see very little focus on mental health and substance abuse. So there's really an opportunity there for those of you who are thinking about solving that problem to begin to integrate these concepts into your solution. And good research to back that up. Next, emergency departments. This is also ARC data based on about nearly 5,000 emergency rooms around the country, showing the breakdown of what these percentages are. You can see on the far right, those are emergency rooms that have more than 20% of their admissions related to mental health or substance abuse conditions. The middle column there is 10 to 20%, and then less than 20%. So about more than 1/4 of the nation's emergency rooms have more than 20% of their admissions related to mental health or substance abuse issues. Again, if we want to make a dent in that high-cost crisis utilization, we need to think about addressing these issues. So, Knowledge Network. Centerstone has been involved in research for a long time. We realized about 5 or 6 years ago that in order for us to really change the industry, which is our vision, we needed to do it through partnership. And if you are in the medical side, you have the practice-based research networks, the PBRNs that have been funded and have been very productive. On the addiction side, you have the clinical trials networks, the CTNs. We really haven't had that kind of infrastructure in mental health, and we were very fortunate 5 years ago to have a donor, actually, a philanthropic donor, put money in, actually several donors put money in to help support the initial infrastructure for a national partnership that would help advance behavioral health as an industry. Currently, we have about 10 organizations nationally, much like Centerstone, that are community-based organizations that are fairly large. All around the country there, you can get a sense of the blue dots there are providers who are parts of our network, and the red dots or the red stars are researchers or other key stakeholders that are involved in the network. And we're always, if you're a provider organization, we're always interested in talking to you about membership. We try to keep it a relatively small number just because of our funding to keep it manageable, but we are interested in growth. There are really 4 areas that we are kind of talking about. One is the idea that we can bring together a much larger population to help support research, and an infrastructure that can rapidly scale up research, test new technologies, test new ideas, and within that share the data commonly on the back end, so we can do essentially, technically I wouldn't consider it to be big data, but it is pretty big data kind of work. There are 4 areas that we chose to focus on as a group. One is advancing accelerating research. So we are actively, we are working with researchers and seeking research partners. We have, through those partnerships, we've received some research funding to help propel certain grants through that system. And those opportunities are out there. A second area is national policy. We work together to influence the national policy discussion. Unfortunately, behavioral health has not had a significant voice at the table when it comes to national policy discussion and health reform. Often these decisions get made and our field sort of picks up the scraps and does what it can. So we've tried to be more proactive in working with national partners and leaders around advancing that national policy discussion. Particularly our primary area has been with respect to health IT, because if you remember the ERA legislation to support meaningful use specifically left out behavioral health as a category, which was a substantial omission that we've been working to correct. And, the third area is implementation science. It's not enough to do research and let it sit on the shelf where other researchers read it. It's really about how do we begin to take that new knowledge and drive it into practice so that it gets adopted and makes a difference in clinical care and ultimately outcomes, the lives of people that we serve. And the fourth area is data and technology. So where we started there is by building, as I mentioned first, this common data backend, what we're referring to, this is a screenshot of Enlighten Analytics. It's essentially built to serve as a business intelligence platform for behavioral health care providers with the ulterior motive, which is thinly veiled, of collecting the data to be used for large-scale research across these sites. One of the challenges that we have in our industry is we have very poor data. We have very poor access to data. We're not able to tell our story using data. You know, when we go to Congress, we use lots of anecdotes about the people we help, and they're very touching, important stories. But as an industry, we're really not able to tell the story about our importance and the difference that we make in the overall healthcare equation. So this is a key strategy. We're also beginning to use this data to do modeling, to really look at how can we improve care, how can we begin to take the same algorithms, frankly, that Netflix uses to tell you which video you want to watch, and Amazon uses to suggest the other books that you ought to buy, and that we all find so helpful in our daily lives, to think about how do we begin to apply some of those machine learning and big data techniques in improving care. One of the areas where we've received a lot of attention in that area has been we've been doing some modeling around people coming into our services. So we're able to, as people come into our services, predict what their likely outcome is going to be based on their presenting characteristics. And we're also able to predict with some level of certainty what the best treatment, what the optimal treatment path might be. So whether it's a medical visit or case management or any of the different treatment options that might be available, we now have some intelligence that suggests what the right path ought to be. Currently, the typical approach, there are two ideas in the field. One is people get the treatment related to the door that they happen to go into. If they present at a residential facility, what do they get? They get residential treatment. The other is it's the kitchen sink approach. Well, if somebody is really hurting and you want to help them, throw everything you've got at them. Give them every service you have. That's a very expensive and often ineffective strategy. Just from this data, and to underscore some of our earlier discussion, if you think about the comorbid health conditions, and this is just from one of our samples, calculating BMI, the BMI percentage in this particular population is nearly 43% for obesity and 27% overweight. So if you think about that, and with respect to our national statistics, Mississippi is the worst state in the country when it comes to obesity and BMI. Their rate is around 34%. So, clearly a problem in our particular population that is very significant. Kind of partnerships that we're looking for, we're always searching for people who have kind of common interests, and we're looking for academic partners who want to partner with us in various ways to either test research ideas or work with this data in creative ways. We are looking for people, software developers, and people with good ideas that they're interested in taking to scale. I think one of the challenges that I see a lot of the small companies around here have is they got a great idea, they have no market. So this is an opportunity to begin to bring some of those things to market and test those in a real-world environment so you can get some traction and sell your product. Of course, we're open to working on clinical trials as needed. We're also thinking a lot about accountable care and how that's going to influence our field going forward, and are thinking about partnerships there, as well as employers. We believe employers are going to drive the future of healthcare in a significant way. So looking ahead, and about to turn things over to really a discussion, is thinking about, we have thousands upon thousands of apps and unintegrated solutions out there. I think a major theme of this conference, as I've sat through it the last couple of days and has been really nice to hear, is how do we begin to bring all of that together in a more integrated, more cohesive, more manageable approach. I think I've heard some really encouraging ideas there, although much work remains to be done. The challenge with the research paradigm, our tried and true methods of funding and review and methodology are really struggling to address the pace of technology development. And that's something that I'm real interested to discuss as a panel and hear the different thoughts on. But I think the availability of data creates opportunities to think about research in a different way. One of the interesting ideas, Ben actually mentioned this at breakfast, was the idea that in the past it was a matter of how do we identify the information that we want to drive into practice, and how do we get that information to the right person at the right time. Now it's more about we have too much information. How do we actually filter the information to make sure that the person is getting it, which I thought was very interesting, and I think lends itself to the idea of using analytics and big data techniques to find that nugget and get it where it needs to go. And also, how do we look at this in an integrated way, beginning to bring together all of the information that's available. Nutrition is a big piece of this, social information, health, et cetera. So with that, I'll turn it over to David Chambers, and we can talk.
For those of you who don't know him, Dr. David Chambers is the Associate Director at the National Institutes of Mental Health for the dissemination and implementation research shop there. And he was extremely helpful in helping us think through, put this panel together, and we've asked him to be a discussant. He's a really important player in this field, so we're delighted he's here.
Thanks very much. And actually, why don't we leave this slide up, because I think some of the points will be helpful in bridging to the discussion. And I think, well, I have to say, Adam Haim, who was also involved in the planning, also from NIMH, is unable to be here today. But the good news is we look relatively similar, I suppose, if you see the two of us next to each other. We both run. We're about the same height. And so just what I'll try and do is channel him through our common physical appearance, and hopefully you'll get some of the same comments from him. But both of us are happy to continue this dialogue. So we're, so first off, very appreciative of my fellow presenters who just did a wonderful job of bringing up so much in limited time. What I'm going to try and do is pick on a little nugget, so even more unfair than the task that they were had. Just a couple of the thoughts that occurred to me as I was listening to their presentations. Give you a couple of items that are relevant to what we've been thinking about at NIMH, and then maybe finish with a couple of overall impressions that, either you'll listen to and you'll say this is way off, or hopefully, you might find some common ground. So in David's opening, I think what's very clear is that we have tremendous number of gaps, gap between research and practice, gaps in terms of who's getting care and how good the care is. We don't have to have these gaps. And maybe now more than ever before, we have tools either at our disposal already or that we can develop that can bridge these gaps in very tangible ways. So we don't have to think about the bricks and mortar healthcare system as the only way in which we can engage, retain, and deliver good care. And that we can think not only about health care systems, but think about this broader health system of who would be involved in a system that's really predicated on trying to maximize health. And that's not the same players that we have thought about, as has been said before, and I heard that from David's presentation. I think from Sarah, what you see is a wonderful distillation of any number of projects that are going after a whole set of different mobile technologies and really applying them toward a comprehensive way of thinking about the different service points. So thinking about assessment, thinking about the delivery of care. I liked the idea of using ecological momentary assessment plus, I would say, because it's not just getting a read on where someone is at any given time, but then saying what is the intervention, what is the message, what is the trigger that enables them to get what they need at that particular time. And so not to only focus on that project, but I think what she presented across the different work that her center is doing is any number of opportunities for us to think really about how our system of the future should look, or how our system of today could look. I think with Ben we got this nice recognition of the challenge that to this point, at least for mental health care and behavioral health, and probably certainly all of health, we've been unable to crack the triple aim, right? We're seeing costs continue to explode. And, whether you're talking about a fiscal cliff situation or you're just talking about over time trying to deal with resources, we need to make, we need to make some progress. I think Ben certainly talked about different ways in which we can approach that, thinking about the interplay between existing interventions and how we can extend the reach, thinking about ways in which we can collaborate and coordinate care in more efficient, effective, and actually more real-time ways, as well as just thinking about newer tools to directly intervene, to directly improve outcomes, not just saying how do we bridge to care as it currently exists. And then I think from Tom we got this very important point that we need everyone in this room and beyond to be a part of the solution. That we're not going to get anywhere if we're just thinking, as we've traditionally thought about research or even as practice, as these silos. And so I think what Tom brings up in terms of the knowledge network and in some of the things that we've been thinking about of other mechanisms to try and build capacity, build networks across different stakeholder groups, is that we're going to need everyone's ingenuity, we're going to need flexibility, and we're going to need progress from multiple corners if we're actually going to get at where David started with the existing gaps and where each one is making a contribution toward them. So I think the first key message that I hope you'll take from this is we absolutely need your help. The second key message I hope you'll take is that this is a tremendous opportunity to make a difference. This is not a time where we can be satisfied with incremental change, but we really have this flexibility, hopefully in thinking, to reshape the entire system. So there are a few things that NIMH has been doing in this space, at least trying to motivate this. One of them is, so Adam represents the Small Business Innovation Research Program, the SBIR program. And there is on the street a program announcement that's really trying to say how can we use even more complex technologies for new therapeutic development and for improving care. We did pull together, and some of the folks at the table were at this meeting, others were not able to come, but in 2010 we worked with the Agency for Healthcare Research and Quality around a very similar theme of why do we recognize that there's such advancement in technology and relatively little of that applied toward mental health. And the group really talked about how we can make a lot of progress in terms of improving access and quality of care. We can do a lot more in terms of pushing the envelope on what is an intervention, at what point can one intervene and improve outcomes. We had a third one which I think resonates certainly in what Ben was saying in terms of the need to integrate data systems and think about what we used to maybe see as this closed-end private electronic medical record as a whole set of data infrastructure that we can all be a part of, we can all contribute data to, and we can all get the benefits from viewing patterns, the large populations, the large collection of data that can emerge if we figure out how to coordinate systems. The fourth one, which I think again was heard in these talks, is just about how we ought to be able to revolutionize measurement. Right? I mean, traditional measurement or traditional assessment in mental health has not been very good. It's often been trying to grab at what happened in the past as some way of trying to get someone's current state and hopefully predict their future state, with the same tools that are embedded in the different studies that the folks on the table are doing, or in the room are doing, as well as just the things that we hold in our pocket. This doesn't have to be the way in which we think about assessing. Behavior is often an elusive thing. Over time, we can gather the data that will help us to much better map what patterns of behavior would suggest need for intervention, what patterns of behavior are normative, and what patterns, more importantly, are normative or out of the ordinary for an individual, considering how much variation we know is in any of our diagnostic categories and any of the people who we're trying to help. We have a mental health research network, which has been this effort to try and pull together, in many cases, the data infrastructure within these 11 nonprofit health systems. This is an NIMH-funded project. And they're very much grappling with these challenges that we need your help with, of how do we ensure comparability across disparate data systems, different sets of data, but that are all really trying to gather the same kind of information. How can we get the right information that enables us to run a healthcare system as well as treat people individually? The sort of final bit is that we want people to dream big. You know, research, at least in our experience at mental health, is often favors the incremental, or often favors the slight improvement on what was already known. And this is a chance for us to really go beyond that. We issued an RFA earlier this year that was predicated on trying to catapult things forward, not do the kind of study that's going to say, is this slight tweak just as good as what we already have? We know about the limits of what we already have, and we've got to drive far further. And so we will see a number of projects over the coming months that we're able to fund through this. But more importantly, we're hoping to see from all of you even more good ideas about how we can pull things forward. I'm just going to end by seeing these are the right questions in terms of our whole view of what a research paradigm is. The right questions of saying, how do we not create a technology that we know at the day that the application is funded is going to be obsolete, probably within 6 months, maybe 12. And I think that we've seen investigators utilize, particularly in some of our exploratory and developmental mechanisms, utilize much more iterative thinking about how do we continue to refine and how do we continue to test. We've heard from some wonderful thinkers around health IT in terms of the amazing amount of constant updating. And we've got to be thinking about that in terms of our research process. And that means that those of you and those of us who are involved in the review, we should not be cutting out what seems non-traditional, because it doesn't fit in our thinking as reviewers of what the study that's going to certainly work is going to look like. So I think we're all a part of the solution. We're all at times a part of the problem, and hopefully together we can make some progress. So thanks.
As a point of, we have 15 minutes left, and we're going to take questions and comments from you in that time. So I hope if you have those, you will come up to the microphone. And while you're doing that, I would just say that over the next couple of weeks, you're going to hear a lot about fighting over federal funding, and hear a lot of people talking about, well, the federal government's too big, we're going to shut it down. And as you hear that, I want you to think about people like you just heard, because the federal government is full of them, and they do really fine work, and they should not be talked about the way they get talked about. So, except in certain departments that are not relevant here. So, any comments, questions, assertions, or rebuttals from the audience? And I know some of you are going to start calling on you. Raising your hand this way doesn't work. You need to stand up at the microphone, ma'am.
Thank you. Well, I can't really reach that. I'm just going to use my big voice for this little body. First of all, thank you. This was great and incredible. My name is Heather Wallace. I actually, full disclosure, I work with Centerstone Research Institute. But I am going to ask this question. Just today in Business Insider, they published an article about social media fatigue. And Tom referenced this kitchen sink approach that's sometimes taken with current care delivery models. And we're talking about all these great ideas that reach across all these different levels of the consumer, of research interventions, and all of this. that we want to use the data, but what factors do you all think or see need to be in place to ensure that the data is received, heard, adopted? What are the factors that need to be in place? We can give it all day long, we can put it out there, but what factors need to be in place for that to happen?
Sir?
I'm trying to see if I have my head around your question. So what needs to happen in terms of for people in order for data to be received
Sure, yeah,
from these
and adopted.
and adopted? You mean how are they going to make meaningful use of the data?
Absolutely.
So I would say that starts very early in terms of even before you start actually physically developing a program, in terms of gathering information from your end user audiences around what is the need and how might they, how is technology potentially going to address the gap, and is it being used in the right way to do that, and so that if your program is actually developed in a way that your goal is to collect meaningful data, then hopefully the data that you produce will be meaningful afterwards. I think there's also an issue, and I hope I'm addressing your question, around how data is presented in a way that's visually can be interpreted. So data display, I think, is a really important issue, and we've heard a lot about it also throughout this seminar, throughout this conference.
Are there like societal level factors? So just like the tipping point model that was alluded to earlier, are there societal level factors that need to tip in the direction of data use?
Let's keep in mind that this is an industry that doesn't collect very much data. Most of the data is collected as handwritten notes that go into files. And so what we're saying is there's about to be an explosion of data coming in that the industry is not used to. And she was mentioning all these sensors all over the body, the GPS of the phone, are you moving, you're not moving, the accelerometers in the phone, did you get up, you sit down, what's your body position, are you lying down all day? You're going to get all kinds of data coming in you didn't have. Plus, out in other fields, like all the physical data is now going to become available to the mental health people. So you get a huge influx of data. And there's a whole industry you don't have but exists to sort through that data and to say, hey, have you looked at this, have you looked at this, and so on. So just on the incoming side, you've got enormous things about to happen that you are not prepared for.
And can I just say very, very quickly, because we have other folks, is that we too often assume that we know what questions need to be answered and that we have the data to answer them, rather than among multiple stakeholders saying, what is the information that you're looking for? And certainly we're, within a lot of research studies, as an example, that we fund, there's an incredible amount of assessment that's done that isn't necessarily answering the questions that someone, if you're talking from a payer organization or you're talking from a provider or even from an individual patient who you would assume wants this particular benefit, whether the data even relates to the benefit that they're looking for, needs to be dealt with on the front end. And there's too long a history of not thinking about that.
Yes, sir.
My name is Gary Austin. I'm CEO of OneCare. And my question relates to the types of solutions available in the marketplace today that can measure compliance or measure behavior with a doctor's care plan for a person with mental health issues. Things like, is there a way to measure if they're taking their psychotropic drugs? Is there a finger stick? Is there something that, you mentioned sensors in the tablets themselves? Are these available today? Are these things that can be interacted with currently for people like OneCare who have systems that can measure, monitor, and report compliance with the behavior? Our systems use behavioral psychology to shape the behavior of the person to get them to be compliant with their doctor's care plans and protocols, and we measure the behavior to determine if in fact they are compliant. We use positive reinforcement to encourage and shape that behavior. So What I don't know is in the behavioral side of the marketplace, as with chronic conditions, you have glucose test strips, things like that. Do you have, are those tools available today that can help to provide the data back as to what the behavior is like?
I mean, it's coming. There are a variety of companies out there. Proteus, for example, is running trials on schizophrenics now, taking pills with the transmitters in them. Is it broadly available? No. Has it been fully studied? No, and that's just one piece of it. Sarah?
Well, just to build on that, I mean, there's just hundreds and thousands of apps out there that are sort of available, but don't have any evidence base yet behind that. So, you know, what we're trying to, I think what part of this symposium is about is trying to sort of get everyone on the same page about building a standard around evidence-based applications in that way.
Yes, sir.
I'm Dorban Zev. I'm also a faculty member with Sarah at the Dartmouth Psychiatric Research Center. So I actually have 2 points. One, I think that the void that exists right now in terms of developing of mobile health interventions for serious mental illness is in the process of being filled. Unfortunately, it's with really, really crappy products. So as you're walking down in the exhibit hall downstairs, I think these are all fabulous applications, but really many of them are not going to be viable for people with serious mental illness who have literacy issues and access issues. And we really, so in addition to all the incentives we already talked about, there's an additional incentive that we really need to compete with these applications that are really not usable by much of the folks that we're trying to target. And I think that that's a really important point, that we need to hustle, you know, to fill this void. The other piece is, I'm wondering, so David, you mentioned, it was really exciting to hear some of the sort of conceptual changes that NIH is going through right now. And I was speaking to Wendy Nielsen, who also talked about moving away from these dated behavioral models and moving into mathematical models of prediction. All that's great, but the reviewers right now are still very traditional in their approaches. And, you know, we respond to the RFAs that are sent out by NIH and by NSF as well. And the responses from some are really quite encouraging, but from others are would indicate a very, very traditional approach towards research and sometimes a complete lack of awareness of progress that's been made with research with folks with serious mental illness over the last decade or so. So I'm wondering, what are the systemic changes that NIH and NSF and the funders are going to engage in to help shift the review process?
Yeah, I think it's a great point. I think one of the things to recognize is that review, and I don't have anything to do with review, so that may be good or bad. But, you know, review really, I think, does reflect back the viewpoints of the broader research community. The people who sit on the reviews and who are assigned the applications are the very people who have the ability to either be quite flexible in their thinking about design or quite constrained. Those who have these kind of open minds, flexibility, understand the challenge or the disconnect between research and the phenomenon that you're hoping to try and provide some insight on, need to be on those review committees. So I think the one thing that we can always say, wherever anyone says, you know, I submitted an application and those reviewers had, you know, and for good reason, you know, get frustrated because the reviewers just didn't get it, are those are the people who we want to be on the review committee. So when I know it's a lot of work and it seems like it's not much reward often, but this is the biggest reward, at least for the broader field, is you can have a system that over time recognizes. And so I do think with some mechanisms and in some committees, over time they've recognized exactly these traditional limitations. Not everyone has. But I think over time, you know, those who are more flexible are probably going to be on the right side of, you know, history, I would hope.
Thanks.
And creating the one exception to the rule that innovation never comes from within an organization, or disruption never comes with. Anyway, yes, sir.
Hi, I'm John Muth from North Carolina State University, and I'm part of a newly formed National Science Foundation Nanosystems Center. And so my question is, we can make all these sensors, but for mental health, what are the kinds of sensors that you'd really like to have?
The last session I was in was maternal and child health, and one of the assertions people were making is, hey, let's create the ecosystem. Let's keep it going because we've got people that do all these different things and they need to talk to each other. Your question just is a perfect example of that, but go ahead.
Yeah, I mean, I think in some cases, some of the same constructs that are looked to in terms of clinical practice are amenable or at least are relevant to sensors. So, I mean, when someone is asked about their patterns of sleep and is trying to remember how well did I sleep over the last number of days, well, certainly sensors that have a pretty easy ability to gather that information in far more detail, or activities of daily living of where was I at different points, have my social patterns changed over time. Too often when we're relying on self-report and everyone's frail memories, I think these are, just as an example, I think these are places in which just existing sensors.
How about physiological things like biochemical parameters or heart rates and things like that?
Mm-hmm.
But I would just add that there's still a lot of basic science to do. There's really this is a whole line of research that anybody here could start writing applications to do, because it is an empirical question about whether the sensors add anything over and above continuous assessment via EMA and such. So those are really good research questions.
Thank you.
Yes, sir.
I'm Ralph. I'm one of the founders of a company called Reify Health. I'm also the useless half of a doctor. Finished the first years of med school. Myself and some of my colleagues left school to build the lab bench for mobile health research. We realized that it's kind of the field's kind of like alchemy and not really chemistry yet. And so we want to make it really easy for scientists to measure what matters, right? To actually understand how we're communicating with an individual, to measure that using different sensors, different text message, smartphone application technologies. My question to you guys, it's really easy to bash the clinical trial, and it's really easy to hate on it and say we need to rethink how we talk about clinical trials and generating evidence, but it's also really hard to propose kind of new solutions. And so I would almost like for each of you, and maybe even a sentence, just to say what is one example of a new way of generating evidence for an effective technology-based intervention. What is some example that you've seen that is an effective sort of rethinking of the clinical trial? If you mind doing that.
I'm on the left. I mean, I think we've definitely seen people capitalize on natural experiments where over time innovations are being introduced into, for lack of a better word, the marketplace, and being able to, whether it's looking at time series to look at the change that occurs at the point at which the innovation is introduced, or at least finding sort of naturalistic comparisons. And I think, propensity score analysis or other ways of trying to provide more appropriate comparisons where they exist, rather where you're not in a position to sort of proactively set up that study, have been used, have been funded, and I think are alternative methods.
So I'm not opposed to the clinical trial at all. I just think there's a place for different methodologies to solve different problems. And I think the clinical trial works really well when you have a well-defined theory, and you can define the sort of the parameters so that you can really test the variable that you can isolate the variable that you want to test, and you're sure enough about it that it's worth the time and effort and money that goes into testing it, so that you have a good enough reason to think that you're right and that it's going to work. But I think there's a whole lot of opportunity to use. Again, I talk about Netflix and Amazon. The same kinds of machine learning techniques in an atheoretical way, because we don't know in many cases what the answers are. This is an entirely new category of research, I think, for behavioral health. If you think about our history over the past 50 years, we've had tremendous innovation in pharmaceutical interventions for behavioral health conditions, and that's slowing at best. Many companies are divesting entirely of their work in that area. And second, we've had great investment in psychotherapies, and that's really slowed in the past 20 to 30 years. We've had specific interventions, but it's really, if you think about the really, in my view, the growth area for what research is in behavioral health, it's really about how do we apply these new technologies to extend and do the other pieces that Ben and Sarah talked about to improve the care that we deliver. But I think it's a matter of not It's not a matter of either or. It's a matter of having the right tool to solve the right problem. I think the problem, what people respond to around randomized controlled trials is that we often treat it as if that is the only tool.
Michael, you get the last question.
All right, thank you. Well, Michael Mulvihill, CEO of Orcus, and first of all, I'd just like to thank the panel. I thought this was a very powerful and compelling presentation. Thank you. Two questions. One is just wondering if anybody might be willing to comment on the growing gloom and doom around FDA and what we may have to go through to get more clinically oriented mobile apps approved. Any thoughts that you might have about that? And then the second one is, we're particularly interested in doing research in the area of the prevention of depression. And there was a point where I felt like our thinking today seemed a little bit more like disease management as opposed to disease prevention. So I just wondered if you had any comments or thoughts about the prevention around some of these issues as opposed to a more disease management approach, which I'm not disputing. But so, two questions. Thank you.
As an outsider, really, to FDA, let me give one comment. One of the things about FDA is that there's a very high bar at the beginning because that's the only bite they ever get until there's a disaster down the road. And when we're setting up systems that allow constant monitoring of very large databases that they can access and everybody else can access, I would hope that they will approach regulation in the same way we should approach research, was this way. And which would be a lot easier for new innovation, a lot easier for small businesses, and so I would hope they would adjust, and I have faith that they will, but you guys probably know more about that.
I'm going to go to the second. I mean, I really, honestly, not being involved with folks at the FDA. We're watching it as it evolves, but we have no specific either insight or anything. So we'll have to see how things go. I mean, I think I'm equally hopeful as David is that over time there will be workable solutions. In terms of prevention, I mean, absolutely. I mean, I think we need to jump ahead of a whole host of problems. I think every issue that was laid out from the front on down are things that we're not going to be solving if we're looking only sort of at the end stage of the phenomenon. And so I think particularly when we can, through the amassing data, understand much better what are the sort of high risk, how proximal to potential onset of a disease as an individual, and how can we arrest that, and ideally, I mean, sometimes whether someone says prevent or someone says preempt, I think we are, or it's just earlier and earlier intervention. I think we're all at a similar understanding that we're way too late when we're thinking about the point at which people access care, and as we heard right from the beginning, less than half of people are even in that window whatsoever. So, yeah, I think open season on trying to find better ways of interrupting and providing the best possible services before people get too far down that path.
Thank you for coming. Thank you for your attention. And if you want to stay involved with a crowd that's we're not formally organized here, but we're thinking about it, so please let one of us know. Thanks for coming.